Hello to everyone from Calgary, Edmonton, across the province, and beyond who has joined us online for today's reverse trade show titled Rapid Solutions for COVID-19 and Continuing Care. Before we move into our programming, I will take this opportunity to acknowledge that in Alberta, we are on traditional territories of many First Nations, Métis, and Inuit, whose footsteps have marked these lands for centuries. My name is David Hogan, and I'm the academic lead of the University of Calgary's Brenda Stratford Centre on Aging and professor in the Department of Medicine. On behalf of our partners, which include the University of Calgary's O'Brien Institute for Public Health, W21C, and Biomedical Engineering, as well as the Brenda Stratford Foundation and the Glen Rose Rehabilitation Hospital in Edmonton, we are pleased to welcome everyone to our virtual reverse trade show. A reverse trade show differs from a traditional trade show because problems are identified that need solutions rather than the other way around. And today, these problems are related to various facets of managing within continuing care environments the COVID-19 pandemic. Normally, many of the fruitful connections that arise with a reverse trade show happen during networking opportunities after innovators and researchers have heard about the problems facing practitioners, patients, residents, and their families. This is when they share ideas about possible solutions to these challenges. Because we can't create this sort of space in a virtual event, a lot of the work will take place after the event, and that's when connections will hopefully be fostered and developed. I'll talk more about this process at the end of today's program. In terms of what we can offer, we are settings for the different needs that you will hear about by bringing you both expert and lived experience perspectives on the different challenges that arose within continuing care as the COVID-19 pandemic hit our province and our country. Next, we will hear about 5 specific problems that have been identified by continuing care providers from across the province that could be solved, hopefully, using technology-based solutions. And there are many more problems that were identified, and we'll share information about them later as well. After that, there'll be an opportunity to share ideas around solutions, perhaps technologies that already exist or can be adapted for the continuing care sector or are already under development. At the same time, there will be an opportunity for the healthcare providers, the residents of these facilities, and others, such as their family members in the audience, to identify other problems that we didn't hear about so far. And this can be done using a tool called Mentimeter, which I think you may have had an opportunity to try already. And it can be accessed by any device that has internet access, including phones and tablets. In fact, keep an eye on the chat box and on the presentation slides for instructions for this and other ways that you can participate during today's events. So now moving on to our program, as many of you know, Canada has done a reasonably good job of managing the spread of COVID-19 compared to many other countries around the world. Unfortunately, of all economically developed countries, Canada also has the highest proportion of COVID deaths which have occurred within long-term care and retirement homes. About 80% or more of all deaths in Canada have occurred in this sector. This has raised alarms around systematic problems that we need to solve, that we need to address. For those who are interested, the Canadian Institute for Health Information released a report comparing Canada's pandemic experience in the long-term care sector with that of other countries. We posted this report, a link to it, and some other helpful resources on our event page, and I encourage you to take a closer look at your convenience. You can find the link to our event page posted in the chat box, and for your convenience, we will repost it several times throughout the afternoon. Now, As we move into welcoming our keynote speakers, I want to highlight that there are different tools available that you can use in different ways to interact with us. I encourage you to enter your questions for our speakers into the Q&A function in Zoom. And you're also welcome to share comments or resources with other audience members via the chat box. We will address as many questions as we can after we've heard from all of our keynote speakers. Please take note that the entire Reverse Trade Show is being recorded and will be available for future viewing on our event page. Now, I'll start by introducing our first speaker, Dr. Jana Holyrood-Leduc, who is a clinician researcher at the University of Calgary and is the incoming head of the Department of Medicine at the Cummings School of Medicine. She's a professor in the departments of both medicine and community health sciences, and is moving up from being head of the division and section head of geriatric medicine to her new job as head of the Department of Medicine. She's also the current holder of the Brenda Stratford Foundation Chair in Geriatric Medicine. Jana has co-authored a commentary about the impact of COVID-19 on Canada's continuing care residents and those working in these facilities. This was published recently in the Canadian Medical Association Journal, and we posted a link to our article on our event webpage. Today, Dr. Holyrood-Leduc will touch on the points made in her commentary and suggest ways that technology can help Canada to mitigate the current challenges we're facing and prevent future ones, hopefully, as the world evolves. Please join me in welcoming Dr. Holyrood-Leduc. Jana.
Thank you, Dave. So good afternoon, everyone. I'm just going to spend a couple minutes with you to give you an overview, as Dave said, sort of summarizing my editorial that I recently co-authored in the CMAJ. So next slide. So I just want to, before I start, to just let you know that this presentation is copyright compliant and I have no conflicts of interest to disclose. And I also aim to use person first language and be inclusive in my language. As well, I am presenting from Calgary, so I wanted to acknowledge the traditional territories of the Blackfoot and Treaty 7 people, including the Siksika, Pukani, Kunai, Tsuut'ina, and Stoney Nakoda First Nations. As well, Calgary is home to the Métis Nation of Alberta, Region 3. Next slide. So if we talk about the impact of COVID on continuing care in Canada, as Dr. Hogan has already alluded to, a recent report from CIHI compared Canada to other OECD countries. So OECD stands for Organization for Economic Cooperation and Development and includes a wide array of countries, including the UK, Australia, Canada, the United States, and a number of other countries. So in this report, what it found that overall the death rate from COVID-19 so far is lower in Canada than many of these other countries. So right now the death rate in Canada is just over 8%, and in Alberta we are just under 2%. However, as Dr. Hogan has already commented on, 81% of the COVID-19 deaths that have occurred in Canada have actually been within long-term care. And this is double the OECD average. As well, the report highlighted that Canada had fewer healthcare workers, so that is nurses and personal support workers or healthcare aides per 100 long-term care residents in 2017 and 2018. The other thing that the report highlighted was that countries that implemented early and specific prevention measures targeted to the long-term care sector had fewer COVID-19 infections and also fewer deaths in the long-term care sector. Next slide. Thinking beyond the COVID-19 pandemic, outbreaks of respiratory illnesses are not uncommon in continuing care. So this includes our annual influenza outbreaks, as well RSV outbreaks are not uncommon. And these result in significant numbers of hospitalizations and deaths annually, contributing both to adverse outcomes for those residing in long-term care, as well as to the overall healthcare system. Next slide. So we need to think about creative solutions to address this identified issue. So specifically, we need to think about novel technologies. Some of the things these novel technologies need to think about is how do we support social interactions and medical monitoring when we also need to be doing social distancing? As well, how do we have meaningful interactions with families during times of medical isolation? There also needs to be mechanisms that ensure social distancing for those that are cognitively impaired and have challenges at following the needed social distancing protocols. All of this care should be delivered in a patient-centered approach, and by patient-centered, we're talking about increasing opportunities for meaningful interactions and activities, empowering the staff that work within long-term care, and as well promoting a home and not an institutional environment within the long-term care setting, given these are the homes for the residents that live there. The next slide. We also need to think about the built environment. Specifically, we should focus on minimizing spread of infectious diseases, so designing rooms that allow for the ability for infectious diseases not to easily spread between one resident to the other, which was particularly noticed in some of our provinces out east where they had multiple residents sharing the same room. We also need to think about quality of life and improving it for those living and working in continuing care, as the COVID-19 pandemic not only impacted long-term care residents, but had significant impact on the workforce working within these facilities. The designs need to ensure that there's meaningful interactions and appropriate care provisions even when social distancing is needed. And we need to think about both indoor spaces as well as outdoor spaces that encourage this kind of interaction. And next slide. I think that's the end of my presentation. Thank you.
Well, thank you, Jana. As a reminder, please enter questions for our speakers in the Q&A function, and we'll get to these after we've heard from all of our speakers in the opening session. I would like now to introduce our second speaker, Dr. Peter Brindley. Dr. Brindley is a full-time critical care physician at the University of Alberta Hospital and a professor of critical care medicine, anesthesiology, and medical ethics. He's authored or co-authored over 100 peer-reviewed manuscripts, 25 book chapters, and so many other articles, including regular British Medical Journal opinion pieces, and even a published poem. We want to ask you to give us a poem, but we have time. I guess we could listen to it. During the pandemic, he's had several commentaries published in the BMJ. Today, he will discuss his experiences as a critical care physician, treating older patients during the first wave of the pandemic. And also, I think he'll be making a plea that if we're inventive and innovative, we can deal with this challenge just as we've dealt with other challenges in the past. Please join me in welcoming Dr. Brindley. Peter.
What an absolute pleasure. Thank you so much. Can you hear me? Can you see my slides?
Yes, I can hear you. I don't see the slides yet.
Oh my goodness. All right. A whole bunch of IT people and I'm having IT problems. Here we go. How about now?
Yeah.
Perfect. Thank you. And you can hear me? I will start now.
Please do.
Lovely. Thank you so much, folks. It's an absolute pleasure to have this opportunity. Very, very best wishes. I'm talking to you today as an ICU doctor, but also obviously a parent, a dad, a son, an uncle, a member of our Alberta BC community. So thank you so much for this opportunity and very, very, very warmest regards as we try and find our way through. Am I allowed to use the term unprecedented? It's unprecedented how many times that term has been used. But nonetheless, because of my experience with COVID and as a sometime author, indeed, I won't read the poem out to you. I was asked to talk about sort of where do we go from here and my experiences and the sort of stuff I've been rambling on about in the BMJ. Thank you so much for your time. So to use a British term, once upon a time I was a Brit, this COVID thing is either going to be an omnishambles, in other words, a disaster economically, a disaster socially, and the end of our medical system, or it could even be the exact opposite. It could be the opportunity we all needed, a time to re-engage, a time to feel re-inspired, a time to realize that every part of the system matters, that healthcare is in fact fundamental linchpin in our economic health and our social cohesion. So it could be an opportunity. Now, why the heck do I have a teaspoon on there? Because I know there are engineers on the line, and if you're like me, you share a nerdy interest in things such as the following. COVID is 10 to the minus 18 grams. It takes about 50 to 70 billion of this remarkable, nefarious beast to make you and I sick. And if you times it by the 5 million or so cases that have been around the world, you're still talking, if it were visible, less than half a teaspoon of virus. And just from a scientific point of view, that's fascinating, especially if you look at the knock-on effects. But it also helps explain why on the one hand, you've got some people denying it, and on the other hand, some people sort of losing their minds over this process because it is such a shocking, scary thing, even if it is invisible to the naked eye. The other point I want to talk about is, you know what, I'm a frontline ICU doctor, but biotechnology, as glorious as it is, doesn't mean anything without the engagement of families, without the engagement of fellow healthcare workers, and without a robust system before ICU and after ICU. I know this from my time working in other areas of healthcare, and even my time working in Africa, where, you know, we were only as good as the weakest link. I was taught this many years ago, and I'm going to share this with you. The real problem with humanity is you, me, all of us, certainly me, we have Paleolithic emotions, medieval institutions, but God-like technology. And that's why whenever I'm given an opportunity to talk to whomever, no matter where they work in the system, I will gladly take up that opportunity. I was taught by my mother that I have 2 ears and 1 mouth and should use them in that order and that proportion. And so let's talk, let's have a dialogue, and let's realize none of us have all the answers, but together we perhaps do have all the answers. We just have to start by listening. Now, this ugly bugger on the left is me. This handsome devil on the right side is my father. The point is, like so many scientists, like so many people, I started out thinking all the answers were in biomedical science. To find a better mousetrap, to find a better drug, to add another machine. And so I've lived that life, and I've had that experience. But my point I desperately want to get across, and if an ICU doctor is saying this, then it applies right across, is that technical medicine in isolation doesn't mean that much. In other words, my life support doesn't mean that much without the family's life support, and without the community's life support, and without rehab after, and without prehab beforehand. For the dog lovers watching this, you'll be delighted to know I'm not going to show this video, but if you do want to look up this YouTube video, it will show you pictures from the 1940s of a decapitated dog kept alive on a life support circuit. It's a fairly horrible video. Despite its provenance being questioned, the point that this gets across, in my mind at least, is biomedicine is exciting and technically advanced and clever, but it sometimes misses the plot. And that's the biggest point I want to get across. So I've highlighted the early stages of my medical career, but I want to highlight where medicine can go if we lose the plot. We all think that most patients are going to experience the sort of top left. Everybody's doing fine, and then suddenly, in a day or two, you pass away. Or top right, terminal illness. But in fact, what I see, and I'm sure what you increasingly see, is this low, gradual, slow decline. Now, that doesn't mean that's not an important decline to manage. That doesn't mean that we should become nihilistic. That doesn't mean we shouldn't try, but it does mean we have to be fully aware of what so many people experience, and make sure that we're not just doing things because we have the technology to do so, that in fact we're being truly empathic, that we're being patient-focused, as the last speaker spoke about, and that we're focusing on the things that matter to them, not just to us. If you fancy a good read during La Vida lockdown, you can't go much worse than this one. David Brooks talked about the second mountain. And I can tell you, so many people in healthcare, and I've done a lot of work on burnout in healthcare and resilience in healthcare and culture change in healthcare. So many people experience a first mountain of externally directed success. In other words, I'm going to invent everything, I'm going to publish everything, I'm going to travel everywhere, I'm going to fill my bank account full of money, and I'm going to fill my CV full of accolades. And then they hit what in the old days was called a midlife crisis, or what increasingly now is called burnout or a lack of engagement. And the second mountain that you have to climb, that I have to climb, is one of internally motivated significance. In other words, what matters to me, what matters to my patients, and what is the sort of legacy I want to leave, not what is the CV I want to leave, but what is the eulogy I want to leave. And I would like to argue that for many of us, COVID has actually been our second mountain. It's been a sense to re-engage, to step back, and to have a darn good think about what it's all about. And many of us are going through this process, coming out the other end saying, this job still matters, this job is darn important, and what a privilege it is to work with motivated people. And so I talked about dad, let's switch it over to mum, because all the best boys in this world are mama's boys. This lovely lady on the left is my mum, who was a palliative care counselor. So son of a scientist, son of a palliative care counselor. My poor mum died in our hospital system, but this is mum driving me out to medical school just before I started and giving me essentially a 12-hour lecture on the doctor I was to become. So if you'll allow me to dedicate this talk to anyone, it's to dear old mum, because nobody matters more. She taught me about ideas like Frome in Somerset. There's no place like Frome. A fascinating study that I'd encourage you all to look up. The idea is that we've got to stop talking about patients and start talking about people who are temporarily patients. Instead of saying somebody's dyspneic and short of breath and therefore needs, let's say, puffers, this is a patient who can't get out and spend time with their friends, can't do the hobbies that give them a sense of engagement and community involvement, and therefore their issue is they can't socially engage, not that they're short of breath. And as a result of this, Frome came up with some fascinating ideas like, let's not focus on bronchodilators and machines and puffers, let's focus on getting a taxi service to that person's house so they can go to their doctor's appointments. Let's focus on hobbies they can do. Let's engage them. Let's take them to the library. Let's even take them for a cup of tea. This is Somerset after all, a cup of coffee, or more integration in the community. And if an ICU doctor is telling you this matters, I hope the same applies for some of the continuing care places that people are working in that are listening to this dirge. As a result, I've moved out of science, and now, to quote Finley Peter Dunn, I believe my job is to comfort the afflicted and to afflict the comfortable. And that's why I write these regular pieces for the British Medical Journal. That, and obviously science, makes my head hurt. What I'm going to talk about is culture change, because culture truly matters. Now, if you'll excuse me being cheeky and talking about the 12 steps borrowed from the Alcoholics Anonymous, and then putting a bottle of booze on the side of the screen, the point I want to get is I'm going to distill down those 12 steps, because addicts will tell you that they were almost lucky, that their life collapsed, that their systems collapsed, that their reality collapsed so much that they had to start from the ground and build back up. And I don't want to get too melodramatic, but maybe that's what COVID is for us, a chance to realize just a second, let's step back and let's go through the 12 steps and rebuild something that works for us. Might sound strange given that most of you are highly functioning people, but bear with me for a second. Let's start by examining what we do for a living. A truly meaningful job, ladies and gentlemen, has purpose, autonomy, and meaning. Pam. This is a picture of pediatric yoga and doesn't look inspiring. Unfortunately, for many of us, work is mastery with no sense of purpose and why we're doing it, and no sense of autonomy, just a sense of, I've got to get this done. And too many patients get processed rather than cared for. So if that's pediatric yoga, unfortunately, this can often be adult yoga. The jokes get worse, by the way. Unfortunately, as doctors and as nurses and as caregivers, we focus on the topics we find fascinating. ECMO, Reboa, helicopters, not necessarily the stuff that truly matters. The next point in our 12 steps is to get across, you can't do this alone, no matter how clever and capable you are. Work out of ICU and emerge suggests 180 steps per patient per day. There is no brain that can do that. This is exactly why at the end of the day, patting somebody on the shoulder and saying, good day today, and them saying to you, but nothing happened, and you saying to them, exactly, starts to make sense. The next thing is, let's apologize. This is a piece I wrote called Dr. Narcissus Will See You Now, and if you read it, you'll understand why. Often as healthcare workers, we think the healthcare system's built for our benefit rather than for the patients, and it's time to apologize. The next thing is rudeness has been shown when injected into a situation like a resuscitation, like a family conference, can be more damaging than most of the medications that we have out there. We focus on leaders all the time. We all want our kids to grow up to be leaders. But the point I want to get across is we've started writing papers and examining this principle of followership. There are 60 papers written on leadership for everyone on followership. We need to change this dynamic because 85% of us are better defined as followers. And a follower is a force multiplier. A follower is somebody that helps get things done. It is not a subordinate. It is not something we should be ashamed of. It is something that encourages you and I to step forward and say, hey, what can I do to help? Many people, they'll say, I don't want to be the follower. That's the subordinate, and they won't let me be a leader. Well, here's your middle ground. Be the first follower. If you've ever seen somebody dancing at a concert on their own, they look like they've lost their minds. What they need is a first follower, somebody to go up and dance with them. And then once that happens, everybody gets up on the dance floor. Be the first follower. And finally, this might sound old-fashioned, but goodness me, this matters. Serve others. Create an emotional contagion of giving a damn in your system. This is a wonderful article from a hospital in Northern England where there was huge use of antipsychotics and restraints in the patients. And 2 nursing attendants took it on themselves to start having tea parties to engage the staff. Their use of antipsychotics and restraints dropped to almost 0. The purpose of getting power, folks, is to give it away. This was said by Anur Bevan. It's said by the RCMP all the time. The point is, all of us with these somewhat secure healthcare jobs are in an incredibly enviable position. And maybe it took COVID to be reminded of that. But we have to take these ideas into the post-COVID era because, let's face it, as Chekhov said, any idiot can face a crisis, but the day-to-day wears you out. It's time for a change, and you know what? It's exciting that we have that opportunity. Thanks so much for engaging me, and the very best of regards with your conference. Thank you.
And thank you, Peter, very much. I'm pleased now to introduce our third speaker, Dr. Vivian Iwa. Vivian's clinical practice includes both hospitalist medicine and inpatient geriatric consult service at the Pierre Lougheed Center here in Calgary. She also provides consultation at the Bridgeland Seniors Health Center, a specialized geriatric outpatient clinic, and is part of the home-based geriatric consult team. Dr. Iwa is also a clinical assistant professor and section chief of seniors care in the Department of Family Medicine at the University of Calgary, and is the medical director of facility living in the Calgary zone of Alberta Health Services. Today, she will share her perspectives on managing challenges related to COVID-19 within congregate living settings. Just before we welcome Dr. Iwa, please remember to enter any questions into the Q&A function, and we'll get to them after we've heard from all our speakers. Now, please join me in welcoming Dr. Iwa. Vivian, please go ahead.
Thank you very much, Dave. Thanks for the opportunity to talk about my experience as a medical director in continuing care during the COVID-19 crisis. Next slide, please. So this was the news headline on the 24th of June, and as you can imagine, very upsetting to not just the public reading it, but also to those of us in continuing care who work in long-term care and supportive living settings. Jana has already spoken to the sort of national background to this study that was actually based on the CAI report. Next slide, please. And so I'm going to focus on the Calgary zone experience here in Alberta, and not just because I work in the Calgary zone, but because if you look at Alberta, that's in Calgary, we had a significant number of cases, not just in the community, but also in our continuing care facilities. The diagram on the left has already been described in terms of the proportion of COVID-19 related deaths. But what I want us to do is actually focus on the diagram on the right. And so we've talked a lot about the frail, vulnerable population we have in long-term care. Well, in Calgary zone, I can tell you that the average age is 81.6 years in these settings. And also in long-term care, over 99% of residents in long-term care are dependent for at least one or more activities of daily living. And when I say activities of daily living, I'm actually referring to just basic, shower, bathing assistance and feeding assistance. So a significantly frail population that we have in our continuing care facilities. But what you see on that diagram on the right is if you look at the yellow bar, you can see that that represents over 96% of our residents that did not get COVID-19. And it's important to highlight that because when we look at the proportion of deaths, yes, it's really very upsetting, but also let's also look at the proportion of residents that did not get COVID-19. Next slide, please. So I'm going to talk about some of the measures that we employed here in the Calgary zone, which is reflective of all the measures that were employed across Alberta and actually across many jurisdictions in the country. And so the first one was the visitor policy. Very early on in the pandemic, we restricted all visitors to our continuing care sites. Within a couple of weeks, we actually relaxed that no visitor policy to exclude essential visitors who were designated either by the family or by the resident in terms of who could visit them at the site. We also developed resident screening tools. This was done daily for sites that weren't on outbreak, and for sites that were on outbreak, we had twice daily screening. One of the things that is very unique about this population is the fact that they typically present atypically. And so your usual respiratory symptoms, fever, cough, and shortness of breath, that were sort of the highlight of a symptomatology for COVID-19 was certainly not the case in our continuing care clients. We quickly realized that just changes in any change in condition, change in function, like increase in falls or not being able to eat or feed themselves, were very significant symptoms when you're concerned about COVID-19 infection. And so our screening tool actually included some of those atypical presentations. Widespread COVID-19 test was employed in our facilities in addition to a widespread contact tracing. We also implemented widespread testing of asymptomatic residents within 48 hours of an outbreak being declared on site. Healthcare worker screening was something we also used. We encouraged healthcare workers to self-screen daily, and on our congregate sites, we actually encouraged them to do that twice within a shift. Questionnaires were also completed on entry to any of our congregate sites, and you had to answer questions with regards to your risk of exposure or your risk of any COVID-19 symptoms. And the screening at the entrance to any of our congregate sites also included a temperature check. We also developed a 1844 number, which was a provincial COVID-19 rapid response number. And so if there were any residents or staff at any of our congregate sites that were experiencing COVID-19 symptoms, they could call this number and get immediate advice on how to manage the outbreak. Continuous masking was also another measure we implemented. I think that was about the 15th of April. And when I reflect on my experience during the height of the outbreak, I must say that this was the one singular intervention that really reduced the risk of exposure to our residents and also helped with regards to containing the transmission at our sites. Next slide, please. Were there challenges in implementing these measures? Yes, there were. And especially when I think about our visitor policy, which really had a lot of impact, not just on the residents, but also on family and on staff. We try to bridge that gap by using virtual means to encourage that connection between residents and families. But again, you look at the population that we're talking about. This is a population with cognitive impairment, a population with sensory impairment. And so there were lots of challenges with regards to using virtual means to facilitate those connections. We had to employ or redeploy staff to help with facilitating these virtual connections. And in the height of an outbreak at a site, that quickly became a challenge as our staffing resources were a challenge. I also have to speak about Wi-Fi access at a lot of our sites. We have a lot of dead areas, especially in some of the residents' rooms. And so that was an additional challenge with trying to provide or trying to support virtual connections. And so a lot of our sites had designated areas within the building where there was Wi-Fi coverage to enable families connect successfully with their loved ones. We also had challenges with regards to IP&C procedures, as you can imagine, using some of these virtual tablets and phones to encourage social connections virtually. Next slide, please. And another area we really struggled with, and I know Jana alluded to it in her presentation, was how to deal with persons with dementia. Deal with wandering, non-compliance to infection prevention and control measures. As you can imagine, trying to have people with, moderate severe stages of dementia to comply with isolation procedures was certainly a huge challenge. We had worsening behaviors. And I think there are a number of things that really compounded the difficulties we were having. For one thing, we had our visitor policy, which meant we didn't have the usual volunteers, we didn't have the usual family support on site. A lot of our recreation activities we had to limit because of social distancing and isolation protocols. And so having to find creative ways to manage persons with dementia really tested our abilities in continuing care. Staff shortages, that was huge. At some points during the outbreak at some of our sites, we were down to 20 to 30% staffing shortage, which again compounded our difficulties with managing escalating behaviors. Medication passes quickly came up as a huge challenge. Getting medications administered in a timely manner was a big challenge. And so using things like, medication compression, so compressing the times at which clients are given medication so that they get the most essential medications at the right time, were things that, both physicians, nurse practitioners had to work with our pharmacy colleagues. And also managing increasing acuity in clients proved an additional challenge to an already reduced staffing resource. And I have to mention that part of the challenges with staff resources was the fact that with outbreaks, we had staff who were excluded by virtue of being exposed. We had staff who were sick. And then we had the single site policy, which was one of the things that we implemented as part of our outbreak measures. And all of that compounded the problem with regards to staffing resources. Next slide, please. Were there opportunities? I would say lots of opportunities. And I think these opportunities really are ones that we can explore even beyond COVID-19 pandemic. And so virtual medical care If anybody had said to me last year, oh, Vivian, you would do virtual rounds on long-term care supportive living clients, I would say no way. But it happened. With the outbreak and isolation and restricting even essential service workers, a lot of medical services were actually provided virtually. So physicians were providing routine care virtually and only doing on-site visits for urgent or emergent care. And then the challenge of what kinds of virtual platforms were safe and secure to be able to successfully do this came up. But over the course of the last few months, we had options of with regards to secure video conferencing that included our Alberta Health Services Zoom platform, Skype that we could use to do this. But again, we had problems with the Wi-Fi, as I've already described. We also have some sites that don't have remote access to electronic medical records. So lots of opportunities there to explore how we can successfully provide virtual medical care. A lot of our specialist colleagues also use virtual means to support our sites. Palliative care was one of our support teams that successfully used virtual means to provide palliative care support. Virtual family connections is something that I think needs a lot of exploration, even beyond having an outbreak at our sites. Because when you look at our families that have families across the world and outside of their locality, this certainly is a platform to explore. Care in place, which simply means that we're able to respond to acute changes in medical condition on site, was something that we had to do a lot of during the COVID pandemic. So mobile diagnostic imaging, collaborating with our community paramedics were things that we used a lot. Isolation units. How do you create a secure environment within an existing facility that can enable persons with dementia wander safely, as well as cohort staff in a place that will mean that you can still care for the COVID-19 positive patient, but enable them to wander safely? I would say that there were opportunities for collaboration across all our care settings and teams. Next slide, please. And finally, I'll leave you with this quote by C.J. Redwine. When I think about the COVID-19 pandemic and I reflect on my experience as a medical director, it reminds me of a storm that we all know is coming. It's been forecasted. I mean, we know exactly what's going to hit us. But when it comes, really you respond to it in real time. And that's exactly what happened with COVID-19. There was a lot of changing information, a lot of evolving information, and we had to respond in real time without losing our heads. And I believe that COVID-19 has presented a lot of opportunities in long-term care that we can all explore, expand in order to provide safe care to our residents in these settings. Thank you very much.
Thank you very much, Vivian. As a final piece of our setting the context, we're privileged to have a chance to hear from someone who can speak firsthand about the interests of those who have been most directly impacted by the pandemic and the measures that were put in place to deal with it within the continuing care sector. I'm very pleased to introduce Ms. Sharon Nettleton, who is one of the founding members of Patients for Patient Safety Canada and a former co-chair of this organization. Ms. Nettleton's career has been in health services planning and policy, and she has worked for many decades in two provinces, Ontario and Alberta. Ms. Nettleton has worked with a multitude of patients, residents, families, health leaders, planners, policymakers, care providers to implement change and help make improvements together. Please welcome Ms. Sharon Nettleton. Sharon, please go ahead.
Thank you, David. Can you hear me? Is the sound okay?
Absolutely.
Good. Well, it's an honor to be joining you today to bring in some of the resident family perspective with COVID and especially in continuing care. I'm but one voice and I only have can only bring in some of the perspectives. There's hundreds, if not thousands more. And that's going to be a key point that I want to bring forward to all of you in this session. I know the focus is aimed at continuing care, but at the outset, I want to encourage all of you to think about holding another session or multiple sessions, and to really look at other populations that have been at risk. One near and dear to my heart as well are elderly, senior citizens, vulnerable persons living in the community and in their own homes. And that's something that in my own community, I've been a part of a team in trying to meet some of those needs. But I would encourage all of you to think about the marginalized, immigrants, racial communities, even our First Nations, refugees, new Canadians, people whose language and culture is not necessarily mainstream, and to think about the impact of COVID and any other sort of crisis on these communities. But back to continuing care, and back to the chat that I want to deliver today. The last 4 months, and looking back on some of those issues, COVID related in long-term care and continuing care, the issues, the safety concerns, resident and family perspectives, you certainly see from our perspective a different picture. Some similarities to the speakers that have gone before, but there's a different perspective, there's a different angle. And I don't think any kind of redesign, fixes, examination of the issues can formally and fully continue without including the perspective, the input, and the engagement of residents, their families, and loved ones. And in fact, I would encourage you to start your work at that place and at that point, asking, listening, immersing yourself in the resident, family, loved one perspective to get that deep understanding. And deep understanding, I would say, of the most critical issues, because we all realize that this was unprecedented, and we're still in COVID-19, and there's still many critical issues that in the long run we might not be addressing as well as we can. Next slide. I'm just going to share a picture with all of you. This is a picture of my mother-in-law and father-in-law when they first entered a supportive living facility here in Calgary about 6 years ago. My father-in-law has since passed away, but my mother-in-law continues to live in a supportive living area facility called Wentworth Manor here in Calgary. She was in her own suite when the outbreak occurred. She is very alert. She's somewhat frail, but she's certainly up on her news and her engagement with family, with friends, and she was certainly aware of the issues that were going on in other care facilities from COVID-19 as it hit North America. I think first Seattle, Vancouver, and then of course in Calgary in mid-March. From our perspective, from the family perspective, we thought Wentworth Manor was one of the early adopters of preventative actions and taking early steps really to further prevent infection and to keep residents safe. And Wentworth and the Brenda Strafford Foundation, from our family perspective, demonstrated tremendous leadership in first warning family and residents of the concern that they had in early days, even before imposing some of the safety measures, but starting to talk to residents and family about it and preparing us, even if it would be only a temporary measure. But as has previously been mentioned, some of the early measures included restricting visitors, introducing higher levels of infection control. We were spoken to about staff masking, gloving, restricting items even from entering the facility, things like clothes and equipment, products that we would normally bring in or have now needing to send in. Then, of course, introducing personal protective equipment for staff, upping, I guess, the cleaning, sterilization, and introducing new policies for where and how staff would work in the Brenda Strafford facilities, and including Wentworth, so that single place of work measure. So these were early, if you like, days in preparing for an outbreak, and the CEO at the time often spoke about just being prepared when an outbreak occurs, and keeping all of us informed. And so they were very, I would say, Brenda Strafford, very transparent with family about what might be coming and what they were currently doing to keep residents safe. And that was a key measure at the time, and a key message. Resident safety, first and foremost, was their top priority. And from our perspective, I think, and certainly mine, the CEO took very much a leadership role in the communication, and the communication to family and loved ones. I can't exactly say how the changes were communicated by staff to the residents. Of course, we're on the outside now as family and loved ones. We as family members certainly communicated the changes in daily phone calls, constant contact as much as we were able with my mother-in-law. And we were passing along these key messages and changes as we understood them through either these weekly updates that the CEO was having in Zoom sessions with family, in updates as they occurred and were posted on the Brenda Strafford website, and in critical emails that were sent out as well. But we then became, or we felt we were, the translators of the information. And so our communication back into Wentworth to, in this case, my mother-in-law, we thought was critical and essential, because we didn't exactly know how the communication was occurring from staff to residents in Wentworth. So that's something that we've chatted to the Brenda Strafford Foundation about, and something we know is on their radar, increasing and perhaps improving the communication and different ways of communicating to different residents. The distress, if you like, of the change and the many changes that were occurring affects different people different ways. It affects residents, of course, in different ways, depending on who they are, what their health needs are, what their emotional situation is, and physical situations. So the translation is really, really important, and for family to know that our loved ones are being supported in different ways by staff when we can't physically be there to provide that level of support and comfort. The communication, I'm going to go back to that though, was really paramount, and we found these regular emails and weekly Zoom meetings, they were a lifeline. And many of us in our own family, we made sure that at least one family member participated. They were also posted so that if any one of us missed it and wanted to go back, we could then go on to the website and listen to the key information that was being disseminated. And it was a barometer. It was an important barometer for us understanding the welfare of our residents. But it was the voice, the perspective, if you like, of management. We weren't sure, although we have great faith in the management, and they have been unbelievable, and the frontline staff over the years. But of course, as in times of crises, you second guess, and when you don't have that direct contact, having another perspective, having another voice, whether that's a care advocate, a resident communicator, something other than someone other than a manager or a head of an organization, might be another way of assuring us of the care. Lots of time in this communication to family and loved ones, to ask questions, opportunities to raise concerns, and hopefully to get management and staff to think about what was concerning us from our perspective, and from what we were understanding of our loved ones, what they were expressing to us. So we were a bit of a go-between, if you like, from residents to staff, and staff to management, and management back to us. Again, as I said, information was posted on their website, and the openness of the communication was certainly appreciated and greatly used. And compared to what we heard from other facilities, this openness, this transparency, this dialogue with staff and management was very unique, and so greatly appreciated by our family, and I'm sure others. After the initial few weeks of the pandemic, I think an outreach and a more personal approach in communication to the family and or to the residents would have eased and addressed some of our ongoing concerns. And I say that because some of the solutions from our perspective were simple, and they're not unique to continuing care. They're unique, I guess, to individuals who are isolated and who depend upon others for assistance, and particularly populations that are vulnerable. And I'm thinking about things like the ability to hear. Many senior citizens, especially elderly senior citizens, wear hearing aids. So making sure those hearing aids can be cleaned, batteries changed, filters changed, they're tested, and it's understood that that process is going to occur, and residents, of course, and family understand that that's not going to be, the ability to hear will not be the limiting factor. Could be things like changes in medication that are concerning to the family, and changes that we see in, and I guess what we would hear in our conversations with our family members. Pain management was something else that was of a concern to our family, as well as changes to health. Could be things like skincare, diet, bathing, other forms of personal care that are important to a resident, are important to our loved ones, and we know that, but the staff of the facility might not be. Often there's a direct person in a family. There's four brothers of Ann and Bill, and then sister-in-laws. So there's a team of us, but we had one brother-in-law is certainly the direct contact, and problem solving, troubleshooting, electronics, and telephone issues that have occurred over the years. So certainly during the pandemic, the lack of his ability to go into my mother-in-law's home, her suite, was a problem. And she often has some technological difficulties. She's got a laptop. She's privileged in that regard. She's been coached and mentored by many in the family, but particularly my brother-in-law. And so when he wasn't able to get in, and she was getting frustrated and calling on the telephone to many of us, and sometimes forgetting that we couldn't come in. We couldn't come in and see her. We couldn't come in and fix things. We couldn't come in and talk to her about comfort and support in times where there was pain. So, the use of electronics, the visitor restriction policies, we feel very privileged having a family member in Wentworth in the Brenda Strafford Foundation, where they helped problem solve as best they could in this time of pandemic, and especially when we knew staff shortages were critical, and we didn't want to weigh in too much in demands. Other things like finding safe places for visits, window visits or balcony visits, could be problematic. And after we tried a couple of balcony visits, some of the family members even thought that because the grade between her room and the balcony wasn't on the level, and as she was getting frailer and not getting up and moving around as perhaps as often as she would with the assistance of family, none of us wanted to put her safety at risk just to get a view of her. And she would say, just pick up the phone and call me, or don't worry, dear. So that's, you know, the safety considerations are a concern.
Sharon, we'll have to wrap up.
Yeah.
I'll give you another minute.
Sure. So I think there's lots of opportunities for looking at physical site. There's also lots of opportunities for engaging directly, next slide, with patients and families, asking residents, their loved ones, and families what the critical issues are, being prepared, anticipating times of pandemic or emergencies, and using the opportunity for simulation, for co-creating and co-preparing. And nothing about me without me is the phrase that often gets used in patient safety, but now I'm starting to see more of it in other areas like resident safety and citizen safety. So I wish you well in this this time of reassessing what's needed, what's critical, and how to reinvent and redesign. And my key message is that you engage the residents themselves and their loved ones and find out what's been most critical in their experiences. Thank you.
And thank you very much, Sharon, for your insights and the challenges you've raised for all of us. Now we're going to address a few of the questions that came during the presentations. Now, if we don't have a chance to address your question, we will forward it to the appropriate presenter for a response following today's event. So all questions will be dealt with as best we can. And I'm just going to read a few questions. We can only deal with a few if we're going to keep on time. So Sarah Cruz wrote, how can we support residents' families in connecting to loved ones in supported living virtually? Family members may struggle to access or use technology, and from an employee perspective, it was distressing for both the family member and the resident when virtual communication failed to work as they had planned. And maybe I'll address that first to Vivian, then I'll ask Sharon to comment. Vivian, do you have any comments? You're muted. Sorry, you're muted, Vivian. Okay.
Okay, yeah, I've unmuted my. Can you just repeat the question one more time? Sorry,
Okay.
I was a little distracted.
So I'll do the Coles Note version. How can we support residents' families in connecting to loved ones in supported living virtually?
Yes, yeah. So really, it's having staff set up the appointment, be present when the appointment is due, and help the resident to log in and use the technology. If we can't use our regular staff, then employing staff that will be dedicated to doing that task. Now, the difficulty we ran into was when, of course, in the middle of the outbreak, where there was increasing acuity, we had lots of COVID-19 cases, that became a challenge, and some sites were unable to support that safely.
Thank you. And Sharon, do you want to comment?
Yeah, I think technology and having additional staff is important, but I don't think it works in all situations. So I think we have to think about a variety of solutions, technology being one of them, but maybe it's an intermediary, maybe it's somebody on the staff who the patient, or sorry, who the resident in this case is most familiar with. And the two of them have a conversation. It could be telephone, it could be email, it could be however the family that wants to connect is able to connect.
Thank you. Last question is, and I'll paraphrase it. Canada had a different experience than other countries, and thinking specifically about long-term care and a large number, proportionally large number of deaths, not in absolute terms. But Jana, did you want to comment on why Canada may have been a bit of an outlier compared to other economically developed nations here?
So I think it's a complex question to answer. I think part of it, Vivian sort of alluded to, our overall death rate in Canada was lower, so we were quite effective at controlling it in our communities and keeping it out of from spreading rapidly in other vulnerable areas. There was a lot of initiatives in Calgary and Toronto and other where they had hotel rooms and things like that where vulnerable populations, such as people living on the streets, were able to isolate. So there was, lots of unique strategies that were done that addressed the spread in the community at large, which I think is why our curves have flattened and we've been actually successful overall. So that but I think the problem, particularly an issue in Quebec and Ontario, was older facilities that had 2 to 4 residents living in a same room, and if you consider that the rate of dementia among those residing in long-term care is high, it was challenging to, keep them socially isolated and apart. And then I think the other thing that we can't lose sight of is the fact that not only does Canada tend to have fewer nurses and healthcare aides per 100 residents, but we also don't necessarily value that cohort of healthcare providers brings, particularly our healthcare aides or our personal support workers. So we pay personal support workers in general across Canada very poorly. And I know when we looked at it in Alberta, they were working across multiple sites because just to make a living, a working wage, which meant they were working well over 1.0 FTE, sometimes up to 2.0 FTE just to make a living. So the fact we underpaid them, and it's talk about a vulnerable population. This is a group of typically racialized women, so I think we don't value. It speaks to the fact that as a society, we're an ageist society, and we don't value people as they age. We don't value necessarily the people that are providing often excellent care, but in situations that is just beyond what they can manage because of the resources they're given. So I think that was definitely an issue. We're not going to touch on the pay issue, but I think that is something that is in the province and also across the country, we need to revisit that, how we pay people that work within this context, and how we support them, and what our expectations are in terms of the number of residents they have to look after. But if we focus on today, I think the redesign, there's lots of opportunities for environmental redesign, trying to think outside the box. Have groups that didn't normally work together, so people from environmental design, from architecture, working with people from the healthcare professions, from IPNC, from geriatrics, from other healthcare, to be innovative and obviously engaging the families and the residents. Think about unique ways to look at novel ways to look at the living environment, and ways to modify it quickly when you need to sort of allow for social interactions, but also keep people appropriately social distanced. So I think that's really will be important. And I would say technology, we need to go beyond just sort of I think it was excellent that the sites were able to quickly use as best they could things like iPads and other internet. But I think technology needs to be thought of more broadly, that there's technologies, there's a way to actually monitor someone's health status without necessarily having to have close contact between the healthcare provider and the resident. So implementing that and trialing those sorts of strategies where you can pick up changes in conditions sooner without having to do a lot of close contact. So I think that's what's so novel about today, is it's starting to work together, bringing diverse opinions, and start to think about how can we be creative in this environment.
Thank you. Now, remember that your questions will be answered, but unfortunately will have to be after the event. I want to thank Vivian, Jana, Sharon, and Peter for their presentations. And everyone can have a brief biological break. Can't have the full 5 minutes, but you can have 2 minutes and 32 seconds, and then we'll restart. I'm joking, not that exact. Thank you. Okay, I think we will restart now. Um, Thank you very much for staying with us. And here we'll be moving on to some very specific challenges and that need to be addressed. And we're hoping that technology might help provide a bit of a solution. Just before we start, I don't know, Julia, can you show the first Menti responses for the first couple of questions we had? I know we were seeing some of the scrolling about the impact, but I was wondering if you could show where people are from and also why people are here. Is that possible? Okay, so we're kind of from around the province. Interesting few outside the province in Canada and even outside the country. Next slide, Julia. So motivation is sort of a mix. One is for 31% was to innovate ways to address these challenges. Another one, also 31%, is to learn about possible solutions. The third most popular one is that we work in the setting, continuing care setting. And the fourth was I want to share possible solutions. So I'm hoping we can make that connection. And can we have the next slide, please? And this word cloud, you can see that family connections came out very strongly, and also use of technology, the appropriate use of technology, and a number of also important concepts in the rest of the word cloud. And next one, please. And this is the impact, and these are all very much personal, and I won't read through each one, but you can see the profound impact the pandemic is having on us personally and on our families. So as I said before, welcome back. And we're now moving to the portion of the Reverse Trade Show where we hear about some of the challenges, specific challenges that the continuing care sector is facing during this pandemic and seeking solutions to respond to them appropriately. To facilitate these sessions, I'm very pleased to introduce to you Mr. Mel Wong. Mr. Wong is currently Senior Advisor to BioAlberta, the association that represents and promotes Alberta's life sciences industry, and is a partner for Synergia, I should say, Associates. I'm sure I mispronounced. I'm sorry, Mel.
No problem.
He retired from being president and CFO of BioAlberta on the 31st of December, 2019, and he had held that position from August of 2015. Mr. Wong served previously as Assistant Deputy Minister of Advanced Technology Industries within the Ministry of Innovation and Advanced Education and Economic Development and Trade. Now, I'd like to welcome Mr. Wong, and I'm now going to pass the mic over to you, Mel.
Thank you, Dr. Hogan. I appreciate it very much. Grateful to be with you, ladies and gentlemen. As I contemplate, and as I'm sure you have as well, throughout the history of the world and human history, we've had crises, and crises have been pivotal in developing new societies and developing our current society. Including in those crises, we've had pandemics in the past. They've helped advance healthcare systems. We've had wars, which have fueled technological innovations. And the global financial crises over the last 20 years have helped advance technology companies. The present coronavirus epidemic or pandemic will arguably be no exception. We can expect entrepreneurs to rise to the challenge. And when I say entrepreneurs, I use that term also to be inclusive of frontline workers, because we know of many instances where there have been frontline workers in the healthcare system that have exhibited entrepreneurship characteristics and desires. The textbooks call them intrapreneurs or intrapreneurship. Now, we know that businesses play a key role in helping society through an economic crisis and in creating innovations that might help us in any health crisis. So one question is, how will the ongoing crisis influence future healthcare society and business? And some of the pitches that we have today will address some of the challenges that will contribute to the answer to that question. So after COVID-19, Canada's people and our economy and our healthcare systems will be forever changed. We see that change happening now. Through this initiative today and others that might follow, we invite caregivers and businesses and other interested stakeholders to collaborate and to contribute to a better world by helping fill the gaps in processes and technologies in continuing care. And before we start the pitches, I do like to remind everyone that while you're listening to them, you can use the Q&A function or feature to enter questions for the person making the pitch. It could be questions of clarifications or simply questions of something that you're curious about. It would be helpful if you could indicate which pitch you're questioning or asking questions about when you submit your question. We'd also encourage you to share your ideas and possible solutions using the chat function. Starting now and for the rest of the event, we're also seeking and asking you to submit ideas and solutions directly to event organizers via the solution survey that we have prepared. That solution survey access can be found in the chat box area. Each survey asks you to submit information for a single solution. So please submit as many different surveys as you wish to. If you have several solutions to propose or are looking for other team members to work with you on these different solutions, we'll be using the surveys we received to guide our efforts to match solutions and problems after today's event has ended. Lastly, as many of you already noticed, we are also polling our audience using an interactive program called Mentimeter, which Dr. Hogan described earlier. Please watch for opportunities to participate in our polls in the chat box and on your screen in the presentation box. So now back to the pitches. Each pitch will be 5 minutes long, and each will describe the problem, what they're currently doing, what they feel is required, and the potential impact. After the pitch, we have about 5 minutes available for any clarification questions or to highlight any solution suggestions that we might want to deal with right away. After you've heard all the pitches, we'll also have more time to consider solutions by raising questions or information input into the Q&A. There will also be a chance for the audience to raise other problems needing solutions. We encourage you to use all the tools available that we've put online today. And as Dr. Hogan mentioned at the outset, a lot of work will take place during this and following this event. We'll connect those with problems and those with ideas for solutions. Our first pitch this afternoon is being championed by Carla Eichert, who is the Manager, Research and Evaluation with Capital Care in Edmonton. Carla, please start your presentation.
Thank you. So as mentioned, my name is Carla. I work with Capital Care, which is located in Edmonton and area. We are one of the largest publicly funded continuing care organizations in Canada. So next slide, please. So today, the issue I'm discussing relates to social connections during the pandemic. So most of our residents are unable to connect to family members using technology independently. The majority of long-term care residents have dementia, and the average age is in their 80s. So many of them have never used video calling apps before and don't own tablets or iPhones. So those of our residents who have dementia, of course, also have short-term memory loss. So they have a difficult time learning complex new skills, like learning how to turn on and use a tablet or a smartphone. There's also an enormous amount of staffing resources that are required to schedule, organize, and facilitate connections during the pandemic. So staffing resources include things like scheduling family members into visit time slots according to the availability of staff, the availability of technology, and around other activities that are happening in long-term care. Also communicating to families their visit date and time, helping families learn how to use new technologies, since many family members are themselves older adults. Setting up residents with the device and starting calls. So different types of visits also have different requirements that staff have to inform family members about. So for example, outdoor visits have very specific rules that were outlined by the Chief Medical Officer of Health that must be adhered to. So family members need to be informed of those rules prior to the visit. And of course, those rules are subject to change. Next slide, please. So just as an example, in one of our larger facilities, we have 276 residents. So if we were to facilitate just one 30-minute video visit for each resident in a week, it would take 138 hours or 6 straight days to complete if we had a single staff member facilitating visits 24 hours a day. And that doesn't include any of the time taken to schedule visits with families or get residents ready for visits. Next slide, please. So there's two angles that could be used to tackle this issue. The first would be developing a technology that is so easy to use and accessible that residents with cognitive impairment could make calls to family members or receive calls from family members without the assistance of staff. So the technology would have to work off as existing resources in the home or be something that could be easily purchased by family members. The second angle that could be used to tackle this issue would be technology to help organize and facilitate the connections to reduce the staff time and involvement. So in the absence of technology that can be used by residents without staff assistance, staff are required to facilitate all connections, and that includes the scheduling and the organizing. These are really large tasks when we're talking about hundreds of residents and hundreds of family members trying to connect each week. Next slide, please. So in terms of our current practice, right now we have a central phone line and an online request form that family members can fill out to request a visit. Not all visit requests come through this line. Sometimes family members call the centers directly. Sometimes residents are requesting visits, so residents ask staff if they can help facilitate a visit. Staff at the centers receive requests each day, and then they have to develop a schedule based on family preferences for specific dates and times. They also have to develop a schedule based on staff availability, the availability of tablets and phones, and resident availability. Then the center staff have to call families to confirm the details of their visit, including obtaining any relevant user information for the tech support and supporting family members who've never used those tech apps before. Each day the visit schedule is circulated and staff are assigned to help facilitate calls and visits. So for outdoor or window visits, for example, this involves staff getting the resident dressed and portering them to the visit location. For video calls, staff typically make the call for the resident and ensure that the call is working. Some of our residents actually require assistance during the entire call to help them stay focused and sometimes to hold the device. Some residents also have trouble hearing the tablet and they require assistance from staff to understand and facilitate the communication. Next slide, please. So in terms of impact, in talking to our recreation teams, some of them are spending upwards of 80% of their days organizing and facilitating visits between families and residents. Minimizing the time that they spend managing visits for residents means that they can spend more time engaging residents in recreation and leisure activities because they are not doing that when they're doing the visits for residents. Next slide, please. Again, still in terms of impact, having resident-driven means of making connections would also increase opportunities for connections because residents could connect with more family members than our current capacity allows. Next slide. And that's it. Oh, I think you're still on mute.
My apologies. Thank you, Carla. If you have any questions for Carla's pitch, please don't forget to ask for clarification using the Q&A function. And also, if you have any ideas on solutions, fill out a solution survey so that we might be able to use that as well. And so we'll just pause for a minute here and see if there are any particular clarifications, questions that we might want to pick up on at the moment. There's a question here about newly built spaces to account for potential infectious diseases and the organizations preparing new bids, what resources available to safeguard their new sites. That's a question from before during the presentations, but I wanted to bring that back because I believe we have someone participating today from an organization called DIRT, Environmental Solutions. And perhaps we could ask them to submit a comment if they might. Is there any construction scheduling software or scheduling programs that might be adaptable to visit scheduling, which would take the load off of human resource staff? So I'll invite whoever's on with DIRT today to potentially throw something into the solutions box for us there. I don't think we have anything else at the moment, Carla. Let me just double check. Someone said, how about a single purpose device, like in the old days when we had a telephone that did just one thing?
Yeah, I actually had the same thought. Something like a button, just a button or a picture of a family member or something that's really straightforward. Like a tablet is really, there's so many steps to get into a tablet or a phone, like a smartphone, to turn it on, you have to know how to push the home screen and then swipe. And it's, so if there was some way of making it so that there's a direct connection that could be very easily facilitated, I mean, that would be wonderful. But
okay, thank you. We'll be coming back to Carla's presentation of any question solutions a little later on. Next, I'm pleased to introduce Michelle Sharp, a recreation therapy professional practice lead from the Central Zone of Alberta Health Services. Again, for the audience, don't forget to use the solution survey or the Q&A function while Michelle is speaking. Go ahead, Michelle, thank you.
Hi, my name is Michelle Sharp, and I'm the professional practice lead for rec therapy in Central Zone for Alberta Health Services. And I only have 5 minutes, so I'm really going to try and jam pack everything into 5 minutes. The technology pitch that I'm presenting today is going to attempt to incorporate a number of different tasks and asks that will enhance the communication and connection between families, facility staff, and residents in congregate care settings. For those individuals with loved ones in long-term care and supportive living, I'm hoping to show that with the use of the technology or platform will enhance connection and communication between loved ones, but also keep family members and caregivers informed, including possibly direct links to important provincial updates and facility updates, access to education, support, and a resource library, as well as location for links for calendars and Zoom meetings and programming, recreation programming, as well as being able to independently schedule visits with your loved ones. Next slide, please. So these are a few of the problems, but they're not necessarily problems. They're a few of the barriers in which the technology or platform will resolve or continue to enhance. So that includes family members unable to connect with loved ones, like Carla had talked about and discussed, the limited communication and facility specific updates. So a few of our guest speakers had talked about this earlier, about being connected and more connected to site specific information, like for example, outbreak status or requirements for outdoor visits, changes in service provisions or visitor guidelines. Also a problem with being able to support and educate and have like a resource library available for those loved ones or caregivers or those family members outside of the home, so that they could have access to information about how to use Zoom, or educating archived webinars as to how to enhance your visit with a loved one who has dementia that is now not able to visit. Also looking at the schedule assist and calendars for the designated central visitors, so that if there's an online option, these social virtual visits as well as outdoor visits and requests for volunteer requests for virtual connection could also be scheduled from the end user. Next slide, please. So I'm going to focus a little bit more on just the recreation programming part of it. So due to COVID, restrictions included no visitors or volunteers coming into the facility. Group sizes were limited and the residents and were socially isolated in the rooms with limited face-to-face social and recreation and quality of life programs. Some sites were also eating their meals in their rooms, so very limited social connection with the residents. Currently, in some of our facilities in Central Zone, the recreation therapists have been creatively combating COVID using programs via Zoom, where the residents in the rooms can use their smartphone or a landline or join via video, and they can visit and talk to their co-residents that are doing the recreation programs on site, so that they can still access those programs via Zoom from their room, maintaining that social connection and programming. Residents have also been accessing Zoom programs such as entertainment, music, museum tours, and things like that from their rooms. There's other provincial programs that have been going on, but if it was a schedule was available with the Zoom link, the family member could actually join their loved one in some of these programs that are happening as well to maintain that social connection. So other examples that we've been trialing here at some of our sites is doing the resident and family council meetings via Zoom. So in particular, there is one site that trialed it 3 years. For the past 3 years, for the resident and family council meetings, there was no actual family members coming into the meetings, not due to COVID and restrictions, but due to distance. So recently when they hosted the Zoom meeting, 20 family members showed up from 5 provinces across Canada, and they were more than happy to have the opportunity to be involved in their loved one's care. So if this technology, if we had a hub or a platform where the Zoom meetings were located and the schedules, then the town hall meetings or information sessions could be joined from family members from afar. Next slide, please. So the requirements for this technology hub would be to look at a user-friendly platform that family could easily access, like a one-stop shop. The other requirement would be that there would be multiple organizers that could keep the site up to date, whether it's site-specific information or provincial programming communication updates or site-specific communication updates, a resource library, as well as a scheduling option so that loved ones could schedule their visits, as well as accessing virtual programming. Next slide, please. So current state right now is that, like we had mentioned before, Carla had said that the schedules, organizing and facilitating are supported by the on-site staff. So that's the virtual visits, resident family council meetings, outdoor visits, everything, the day-to-day care is all being provided by the on-site staff. So the potential for this platform is that if these links and available services, supports, and scheduling were found on this platform, then family members would be able to book some of those services independently and have access to global programming and information and connection. So the impact would be that it would optimize our resources. It would be located in one location. Families would be more involved, informed, and connected, and it would improve day-to-day interactions and quality of life for the residents and the family members, and enhance communication, connection, and socialization. Now, these are some of the things that we're talking about COVID, but we've all talked about these restrictions have been put in place because family members can't come in. But we all know that a lot of the loved ones in long-term care and supportive living have family members or supportive caregivers that live in far ways away in distances. So having this technology and options available would be great to continue, not just during COVID, but from now on. Next slide, please.
Michelle, I'm sorry.
And I'm done.
Wrap it up? Yeah. Okay, super. Thank you. Appreciate it. So we have just a minute to see if there's any questions for clarification for Michelle. I see a few comments come in from DIRT and also Michael Callis, so U of C, has asked if he could work with DIRT if they're interested in working together to find some solutions. Is there anything here directly for Michelle? Not at the moment, so we'll come back to you, Michelle, later on, okay?
Thank you.
Very much. Appreciate that very much. So I'd like to move on now to pitch number 3. We'll be hearing from Alyssa Lau, who is a registered nurse with the Wing K Care Center in Calgary. Again, don't forget to keep your questions coming in and any solutions you might want to suggest. Alyssa, please.
Hey everyone, so I'm Alyssa. I'm here from Winky, and Winky is a care facility in Calgary. We have 320 beds across 3 sites, so 2 long-term care, 1 supportive living. Like Carla's mentioned, we have had a lot of similar issues with communication because our residents are also those with dementia and people who don't have that ability to communicate as well. So our families are very supportive, and what is common in our facilities is that we will have families who come in every day. They come in at meal times, they eat with the family members, they spend some time together, and we often see that is that quality time that they get together because they can be here for as long as they want, that they've now lost because they are not allowed into the facilities as precaution for COVID. And oftentimes with our Zoom visitations and with our Zoom visits and our window visitations, we see a lot of, hello, over here, can you look down at the screen? I'm right here. Or through the windows, you see a lot of teary eyes. People see their family members, they want to touch them, they want to say hi, they want to communicate in that physical way. That just can't be done because there is that barrier between them. We talked to a lot of our family members at our family town halls, and overwhelmingly, they're very appreciative of the fact that we do have our Zoom calls. They love the window visitations, but at the end of the day, they're still telling us it's just not enough. And what it is that when families are able to visit day to day, they get a different kind of information than when you're communicating over Zoom or through a window visit. And there are increasing concerns that are heightened by COVID-19 because there's concerns about their well-being. They're concerned about what type of activities are happening in the facility now. They're concerned about sudden health condition changes. They're more concerned about well-being. They have questions like, did they sleep? Did they eat well? What happened today? And it's those day-to-day things that they don't get that they want more information on. Communication is essential for us. Like, it's a huge part of what we do, and we want our families to really be reassured when they have their residents here that everything is okay. And can I get next slide, please? Sorry. And next slide again. So what we're doing is, next slide. Sorry. So what we're doing is we're asking for a platform that can be used to supplement these current Zoom visits and physically distant visits. It needs to be something that is ultimately easy to use for all of our staff and their family members, because we do have not only different technological capabilities across both our staff and families, but also often a language barrier. A lot of our residents and their families primarily speak Chinese, so it can't be anything with too much English, I suppose, or with a second language support. Also needs to be something digital. We're looking for a platform that works both on a PC, can't be limited just to tablet. And then we're looking for something that can capture the information that we already chart on every day, the food, what they're doing, their health updates, and sending it to these family members so that they have that more frequent touch point. They get more feedback from our professional staff. Because when they're calling us all the time to ask those simple questions, it's not that we're not happy to answer them, but we do have 320 residents and only so many staff who can answer these questions. We've seen apps similar to this in both daycare settings and for like pet care settings. So we're not quite sure if that is possible, but we'd love for it to not require too much duplicate charting from what we're already doing. We're currently using a system called Point Click Care. Can I get next slide, please? And currently, as I mentioned, we already do the weekly Zoom calls and visitations, but we also do a monthly phone update from the nurse, which is a more health-focused update that we have always had in practice for all of our residents anyway, but we could just supplement that. So, yeah, and can I get the next slide? So the goal is really just to alleviate the family concerns and their stress and to provide that reassurance, because we know that obviously having your loved one in long-term care is generally already something that, you know, that makes a lot of family members worry a little bit. And so to not add to that burden and miss everything that is happening in COVID, and just to enhance the communication between our staff and families. And can I get the last slide? That's it. Thank you.
Thank you, Alyssa. Appreciate it. Again, if there are any questions for clarification for Alyssa, please use the Q&A function. Meanwhile, while you're doing that, I'm going to throw this out there. There was a suggestion that is there any way to have a tablet initiated by the family with the tablet mounted in the client's room, and that way it can be used for scheduling perhaps, or for other purposes, leaving messages and whatnot. So I throw that out to our first three presenters, if there's anybody, either one of you would like to respond to that. Carla, is there anything that you'd like to say on that one?
Yeah, I was just gonna jump in and say it's a great idea. Um, I was thinking something too like a kind of like a bat phone, where a resident can just pick it up and it goes directly to their primary contact, for example. The only challenge I would see with this is that the resident has to be in the room when either the family member calls or the resident wants to make a connection with the family member. But certainly, that's a really interesting idea.
Okay. Michelle, anything you want to comment on?
Yeah, there's been a few things that we've been doing, and IT has offered, they have a tablet that is just kiosked out so that it's just has Zoom on it. So the resident or the patient can then enter in the email address of the person that they want to Zoom, and then they'll pick up immediately. So it's just kiosked out. But I think the problem is that with our residents that are in long-term care and supportive living, especially our dementia clients, they need that extra additional support in being able to run it, hold it, access it. And then the fact that there's limited Wi-Fi connection as well. We've also been trialing some different things where in previously years past, there's been you can use Skype with the camera where it automatically answers. So the resident or a person that's not able to touch the screen, it automatically answers, but it needs to be very simple, the technology part of it, but the actual and the support of that individual being able to hold it and be cognitively aware to actually run the technology too, and physically be able to use the device.
Thank you. And I'm assuming that most residents would have televisions in their rooms. They would supply them on their own, I presume, in most cases. And there would be no guarantee they would be smart televisions to use the internet on. So that might be a limitation factor in some of these rooms. Alyssa, any comments?
No, I think Michelle really covered it. It's that it's not the availability sometimes so much as it's a lot of the support that our residents need. Like we do have a resident here who gets daily Zoom, he Zoom calls with it via a tablet that was it's a personal item, but he does still need a staff member to kind of set it up, prop it up for him and kind of cue him so that he doesn't, start getting distracted or anything. So that is something we've had experience with.
Okay, thank you. So we've heard the first three pitches now. So we had Carla and Michelle and Alyssa. They focus primarily on communication and social connection. We're going to switch gears just a little bit now. We're going to have our fourth pitch, and it comes from Heather Gale, the Director of Nursing at Calgary's Brenda Stratford Foundation, Beauview Manor. And so once again, keep your solutions and your questions coming. Heather, all yours.
Excellent, thank you so much. So just starting out, I just wanted to offer a little bit of background as to kind of where my pitch is coming from. So yes, I am working in the role of Director of Nursing right now for Beauview Manor. However, that's a recent transition for myself. Prior to that, I was actually working as a clinical nurse educator at our Clifton Manor site. So did work through an outbreak that we had there where we quickly went from 1 resident to 27 residents in a very short period of time. And as you can imagine, there would be significant change of, practices and protocols that happen, really, really quickly, given the fact that we were one of the first sites in Calgary to go into an outbreak, so back in March. So more so what this pitch is looking at is having a little bit more of a conversation around support for staff and having some type of tool that we could utilize or technology that we could utilize in order to reinforce and translate infection prevention and control practice into their practices. So next slide, please. So our main problem is looking at how do we reinforce these practices that we have taught our staff. They do know what to do. They know how to protect themselves. However, we are working in a complex environment. With there being a complex environment, many people today have already kind of had a discussion around how do we enforce IP&C practices or infection prevention control practices with residents who do have dementia. So there's that variable. The other thing is through periods of times of uncertainty, change, and heightened stress. So there was a lot of fear in and around the practices that were changed for staff at a very quick time frame. So for an example for you guys, just so you understand where I'm coming from, when we went into outbreak, we had a very quick turnaround that everybody had to then move to consistent masking. So where we wore surgical masks all day for our entire shift. That's not something that is common practice in healthcare. So people would just come to work and without having, a lot of information around how long they should be wearing it, when they should change it, the donning and doffing or putting on and taking off practices changed really fast with minimal relayed information to the staff. Other pieces with that education is the heightened stress around COVID in general. And there was a lot of fear, and a lot of that fear I truly believe came from there being a lack of knowledge around what was happening. So we're wanting to look at ways that we can reinforce previous knowledge, be able to translate some of this information to our staff at a really quick turnaround, and not necessarily just using email as a tool to communicate with staff, because we do see a lot of our frontline workers are not necessarily checking work emails and things like that really quickly. So coming up with a form of an educational tool. Next slide, please. So again, those requirements, looking at that method to communicate those rapid changes, looking at a way that we could potentially evaluate the retention of knowledge or that translation into practice. This is a little bit more of a difficult ask, so I'm asking people to put on their brainstorming hats here on looking at what could we do to be able to evaluate somebody's knowledge using technology in a really fast changing environment, because the reality behind all of this is, as somebody learns something new and it has to happen really, really quickly, there's not really a lot of time for a lot of repetition. And in the absence of that repetition, how much information is actually retained in a period of high stress? Most adult learners struggle the first time they learn something to remember all of it anyways. We'll see, 20, 30% retention, and that's a good thing if they are able to do that much, and sometimes it's less than that depending on who we're communicating with. So looking at ways that we can assess what that retention was, and then finding some way in order to have repeated use. And then of course, from that technology standpoint, having a way that it is really easy use. So again, same type of things that everyone's been talking about today. We've had advancements in technology, but now we actually want to revert things back to making it as easy to use as possible. Next slide, please. So our current practice right now is that we do train our staff on how to utilize their PPE and have them do return demonstrations back to us. So with that example I talked about before in regards to consistent masking, that was a change in practice. They already had information on how to wear a mask, but they were taught to put on a mask before going into somebody's room. When you come out of that room, you take off the mask. And now we're asking them to have it on all the time. So there was a lot of questions that came back around, well, how long can I wear it for? When does it become permeable? Things like that, where that information could have been shared a little bit better on what those practices should have looked like. We do teach about methods of transmission as well as the chain of infection. Through a pandemic, we did do a lot of in-time education sessions where we would go out and actually provide feedback to staff. However, most continuing care sites might have 1 or 2 educators and upwards of, anywhere between 200 to 400 staff. So that type of feedback doesn't necessarily relay enough information. We trialed having a buddy system where they were giving feedback to each other, as well as engagement in IPNC games for learning. And in a high period of stress, there was a lot of challenges around having people commit to that and being engaged, as well as an IPNC lead person. So those are pieces that we did put into place, but again, we still saw some gaps in that knowledge retention. Next slide, please. So in regards to impact, ultimately, if the residents receive care from staff that are well prepared, very knowledgeable in those new practices, there will be positive resident health outcomes in preventing the spread of infection. It enhances staff occupational health and safety, contains that spread and outbreak management. And then the positive mental health outcomes that come with that is mainly in relation to knowledge can help decrease fear. We did have some staff that were so frightened that they would bring this home to their family members that they didn't want to work or were afraid to work. So looking at ways to better prepare our staff with an understanding of how to protect themselves could decrease some of that fear and some of those and improve mental health outcomes. Next slide. Oh, and then that's it for me.
Super. Thank you so much. Appreciate that. I do have a few clarification questions that have come through, Heather. The one question was about employee safety, culture, training, assessment, enhancement. I think you've answered the most part of that, but if you care to add any more into that, we'd be happy to hear from you on that. I'm just going to throw all these three questions to you at the same time, okay?
Okay.
In the interest of time. So that one is on employee safety training. The other one is, do staff use a mobile technology on a smartphone to communicate? Example, secure messaging application on a smartphone. And number three is, could you use wearables? Buzz when you do things wrong, pair with app with point system for learning new procedures, updates done automatically, app with a daily quiz or update that worker does on entry to facility.
Yeah, so honestly, that's exactly what it is that we're looking for, that last piece in regards to wearables. We don't have anything like that. That would provide that direct feedback to somebody when they did something wrong. So that's kind of what we're looking for. And that's why I said, kind of thinking outside the box, I've never heard of anything being utilized like that in healthcare. So something like that would be really good. Currently, we don't have our method of communication to staff in regards to changes is email communication and then in-person conversation. Given that the amount of people that there are that come in and out of our building every day, it does make it difficult to ensure that they have read emails, especially our frontline staff. You know, our nursing staff and our leadership team, they are very good with checking their work emails. But when we look at people that are working in our laundry services and food services, they still need to have all that same information, but might not actually have a work email.
Okay, thank you. There's a few other ones came in. Sam has asked a question, and incidentally, Sam and his company have developed a new COVID-19 screening and tracing facilitation software and device. So I invite Sam to share that maybe in the solutions survey. Sam says, could you incorporate a knowledge-based questionnaire during the daily screening process for staff? An online questionnaire could be completed by staff before coming on site. Questions can be modified on an as needed basis to accommodate changes in procedures and training. Yeah,
Something like that would be great. Currently not something we're practicing. There are, you know, memos that are posted as somebody comes into our building. The only thing that I do foresee as a potential issue around doing that type of assessment when somebody is entering the building, if it was something that was done on spot, then we already have huge delays in the screening process of getting people into the building, given that our shift change all happens at the same time. So most people are delayed getting in by 10 to 15 minutes as it is if we're going through those full screening. But if we could develop something online that they did in advance to assess that knowledge, I think that that could be a tool that we could use.
Thank you very much, and I appreciate, Heather, for your time here today. Our final pitch this afternoon comes from Scott Berg, a senior operating officer with Covenant Health in Edmonton. Again, a reminder, please use the solutions survey, the Q&A function as well. Scott, you may go ahead.
All right, thank you, Mel. It's a pleasure to be here today, and I think the different pitches that have come before me, I think those are things that we experience and challenges that we have as well. So it's nice to see them presented here. And this really builds on the IPC issues that Heather was speaking about. So next slide, please. So really what we're talking about here is the problem. Obviously, we've talked about the prevalence and the impact of COVID-19 in continuing care settings, with 81% of deaths in Canada reported in long-term care. And one of the challenges that's been identified within some of our facilities is that appropriate or contained space for donning and doffing PPE. And along with that is, do we have that safe place for the staff to do that? As Heather also alluded to, there's a great deal of anxiety among staff and moral distress around bringing COVID home to family, but also not fear of bringing it into the facility because they've seen the devastating effects that can happen if COVID does come into the facility and the outbreak begins. Next slide, please. So what the idea is around this portable anteroom is a pop-up room, if you will, that can be set up easily outside either a resident room or maybe even as you come into the unit, where staff can don their PPE as they're coming in to the space, or doffing it as they're leaving that space as well. Some of our facilities are older and they don't really have enough space to do that. So this would kind of contain that area. Some of the things that we would need it to be, obviously, is easy to clean from an infection prevention control standards perspective, fit within some space constraints, and potentially be something that is adjustable, size adjustable. We have seen units somewhat like this when they're doing construction within a hospital setting, where it can, I guess, adjust and go up to the ceiling if they're cutting a hole in the ceiling to repair something, with HEPA filters to remove dust, that kind of thing. So something potentially along that line. Thought as well, if it was something that was see-through, so that you could also observe staff doffing their PPE, because we know that's also a time in the process where contamination can happen, and breaking that chain of PPE. And you could also incorporate into that some storage supplies as well. When we have residents who are suffering from dementia, they can also get into where the PPE is stored. Actually, next slide, please. So the current practice, staff would don and doff PPE in the open area outside of a resident room. For instance, there might be a cart with gowns, that type of thing, and a linen container for disposing of gowns. And again, this is where potentially residents could get into those supplies, and then having some contamination there as well. So this would, again, just provide us a safer space there. Next slide. So ultimately, the impact, what we're wanting to achieve is reducing the transmission of COVID-19 in long-term care facility, and also decrease that stress and anxiety for staff around spreading COVID, and that's a significant issue and concern for our staff. And next slide, we'll just, I guess, turn it over to questions.
Thank you. Appreciate it, Scott. So are there any additional questions? Let's have a look here. Scott, there's a request for you to contact Anita McKenzie from C West Custom Fixtures. They might have something. That's a suggestion from Michael Callis.
Great, thank you.
All righty, and I also like to suggest that maybe Dirt and also Scott get together and have a conversation too, given Dirt's experience in building structures and whatnot. There you go. Dirt says that we also may have a solution. So there, I anticipated that one. Here's one from, let's see here. This is a critical piece indeed. We are bringing some latest user-friendly telepresence robotic solutions to Alberta that are being very successfully implemented in jurisdictions around the world. Happy to share in the solutions survey. So we look forward to that. Thank you, Sana. And have you ever looked at the industrial portable clean rooms, Scott?
So that's what I was referring to. I think that what we're talking about is the same thing regarding with construction and creating that space where they can do construction without having dust and that type of thing contaminating the area.
Okay. Thank you. Time for one more here, perhaps. Okay, there's been some background information going on. So Scott, you can expect some follow-up on your presentation as well, okay?
Perfect, thank you very much.
Thank you for your presentations. Carla, Michelle, Alyssa, Heather, and Scott. Thank you for sharing those pressing problems from a practitioner's point of view. I'm sure you'll be able to remain available to answer any questions specific to your pitches during our following discussion on solutions. So we shift now to the final stage of today. I want to tell you a little bit more about how it works. As you know, in a normal reverse trade show, it would be time when innovators and researchers could make in-person connections with healthcare providers. We obviously can't do that today. Instead, we have 4 different ways, some of which I've already mentioned, that you can build connections and share ideas. And our organizing committee, a lot of people working behind the scenes today, grateful for their help, will continue to facilitate these connections after the event is over. Number 1, share reactions, links, ideas, and information with each other using the chat box feature. 2, direct questions or ideas using the Q&A feature will help facilitate those that perhaps we don't have time to discuss today, but we'll put you together after the event today. Make sure your questions, again, are directed to the specific pitch champions. And of course, submit any and all solution ideas in the solution survey. Once again, filling out as many solution surveys as you'd like and directing it to a specific individual. Again, that feature is in the chat box. Finally, we realize that there are a lot of challenges out there, many of which have not been able to be brought forward today. We don't have time to cover today. And many of these can be found on the event website. But we're also asking everyone in the audience to suggest other problems needing technology-based solutions that will help us better prepare for a second wave of COVID-19 and other infectious diseases in the future. We once again ask you to submit them using Mentimeter. You can do this using any device with the internet access. Instructions and access code are on the chat box as well as on our reverse trade show. So maybe at this point I'll pause and ask those behind the scenes to show any particular answers we might have on Mentimeter with the last 3 questions that we've had on that meter. So which challenge or issue or challenges resonate the most with you after hearing the pitch presentations? We see all of them, resounding majority saying all of them are identified with. So that's fantastic. Communication between facilities, staff, and families and residents. All right. And then the 3rd place would be reinforcing IP&C control practices from Heather. So all of these have had definite interest. Next question. Are there any challenges in continuing care related to COVID-19 that require technological solutions that have not yet been identified? We have yet to have any data on that at the moment from our audience. So we'll, I'm sure, be able to fill in the blanks a little later on. And the last question, what are the main barriers to making these changes?
Mel, I haven't opened these questions for submission yet, so I just want to have a chance for people to submit to any other challenge areas first, and then we can go to barriers next.
Okay, so thank you. We'll have to come back to that, or maybe you'll circulate that after the event. So let's get started. If there are any other Q&As, let's go to that now. So I'm going to just have a look here and see what can we learn from this, from the experience of Ontario and Quebec in their facilities. Anybody care to answer that question? Any of our presenters? Okay, we'll leave that for another day then. Next question, are hand washing facilities hand sanitizers available in areas of Heather and Scott's proposal? PP is important, but not before proper and regular hand washing. Heather and Scott, you want to respond?
Yeah, absolutely. That is something that is readily available absolutely everywhere within our facilities. So that for sure is the forefront of the education that we provide, and we make sure that those products are there for the staff. Sometimes we did run into a shortage throughout the COVID-19 pandemic, but we were able to secure products from very different places. So breweries, different things like that. So it wasn't always the, as comforting on their hands as our original products were, but we still made sure that we always had those things in place.
Okay, thank you, Heather. Scott?
Yes, I just echo what Heather said. Definitely, always available and high priority. Yeah.
Okay. All right. So we have an offer from the BME faculty at the University of Calgary to work with any of you if you care to work with them in terms of finding solutions. Also, there's a referral here to, let me just find it. I'll have to come back to that. I just can't find it at the moment. It was, oh, here it is. Access eHealth Technologies, accesshealth.net. Involves the communications problems between all key stakeholders of a long-term care facility, etc., between caregivers and healthcare providers. So here's a suggestion to look at Access eHealth Technologies and the URL accesshealth.net. So I'll leave that out there for any of you that are interested in following up on that. Okay, let's go back to Mentimeter. Are there any challenges in continuing care related to COVID-19 that require technological solutions that have not yet been identified? There's an interesting one. Accessibility to funding. Anybody solve that problem? There are some organizations that are trying to encourage the province not to be just focused on a first-time buyer situation, but be a first trier to test the technology, because a lot of our industrial providers of solutions don't have a great place or an easy place to find testing facilities or sandboxes, so to speak. So I throw that out there for information. So there's lots of feedback here. People who want to communicate via touch. That's an interesting one, isn't it? Facility testing, real-time stats for staff, residents, and family. And they just keep coming in. Thank you for all that. Keep them coming in. We appreciate that. Okay, I'm going to go back now to Q&A and see if there's any the last minute here. Again, a comment on funding. Very difficult to introduce any kind of technology without funding to pay for the technology, as well as IT support and maintenance. Who would pay for the technology, the individuals or the facility? Anybody want to comment? Scott, in Covenant Health, I'm assuming there's a combination of funding sources, right? There's the whatever budgets are available. Secondly, whatever new funding might come out in terms of government initiatives. And then thirdly, would be the families.
So with Covenant Health and continuing care, it would be like any other continuing care facility where you have the accommodation fee that families would pay, and that's more for the housing components, and food and housing kind of component. And then there's the funding methodology around the care. The challenge is when you want to look at new technologies is a bit more challenging to find the resources to do that.
Yes. And the new URL that the province has available to encourage companies to help solve problems, I think is BizConnect, I think it is. there might be something that come out of that, because there's probably more than just matching there. There's probably some support for funding. I know that we've had someone from IRAP online scheduled. Anybody from IRAP want to respond to that in terms of your programs? Please put it in the solution survey. Michael Callis has a couple of comments here. Heather, need an app that knows your location, would know when staff last entered or exited, and if the protocols had changed since they were last there. Only need to do the entrance quiz of something if someone is new or something is new. Heather, you want to comment on that?
Yeah, that would be excellent. I do wonder in regards to, you know, how that would work. So are you meaning on a phone type basis? Because then there's the pieces around privacy and things like that. I don't know what that would look like from that angle, that we're kind of tracking where people are, if it only turns on when they come inside our building.
Mm-hmm. Okay, thank you. And then Michael also has another comment. The key would be to find technology that reduces overall costs when possible. Need to look at system-wide suggestions. You're right, Michael, because that would have a lot more appeal, wouldn't it? And someone's repeated the question, can we learn from the experiences of Ontario and Quebec? Is there anything that we can glean from that could be applied to your initiatives today? Anybody want to take that one on? Okay, while you're thinking of that, I'm going to return back to Mentimeter. What are the main barriers to making these changes? The number one answer, access to funding. Here we go again. Number two, complexity of residents. And tied for third space is shifting current care practice. And there's three tied for fourth place, commercialization, piloting, trialing challenges, and design technical challenges. Knowledge awareness level is next. Next is securing private sector industry support. I know that this whole initiative today is to encourage private industry and caregiver collaboration. The organization that I represent, Alberta, is also interested in supporting that and also in encouraging that. So if any of you would like to find appropriate partners or would like to have some inquiries into private industry, specifically, maybe Alberta could help you with that. You can contact me after as well. All right, thank you. The answers or the suggestions keep coming in. Thank you for that. I'm going to go back to Q&A again, see if there's anything else. There are no additional Q&As at this moment. And someone asked about recordings of this event, and it will be posted on our event website after the event is done. So we are nearing the time for closing. I want to thank everybody for their engagement and their ideas, their questions, and their participation. We can send up a follow-up email to all those registered for the event with links to the surveys and to the Mentimeter tool. And once again, thanks for great ideas and engagement. And so I'm going to turn the time back over to Dr. Hogan for his closing comments. Dr. Hogan.
Great. Thank you very much, Mel. I think we heard a lot about skillful and collaborative development, adaptation, and adoption of technology to address some of the general and very specific challenges we heard this afternoon. And clearly, technology will be part of our solution to these difficulties, but it's not the only resource or response that we should consider. And I think for it to be fully effective, technology has to be integrated into procedures, practices, and policies of the continuing care sector, and also has to be developed in a collaborative way. And that would be a collaboration between developers and practitioners, residents and their families, and all have to have a seat at the table. Part of our motivation for doing this is to try to change or improve the story that we've been hearing about long-term care, continuing care, and COVID, and the situation in our country. And we're hoping to foster innovative and creative responses to the challenges of COVID-19. We also felt that this was a time-sensitive issue because unfortunately we are anticipating a second wave in the fall, and that COVID-19 will be with us for much longer than we really do want. Now, just before we all part ways, I wanted to remind you that this afternoon's activities are not an ending point, it's just a starting point. And we want to foster and develop connections, and we want to work collaboratively and cooperatively together towards putting technology and technological solutions in place as quickly as we can in the continuing care sector. In the coming weeks, our organizing committee will be reviewing and collating all the information received this afternoon, and much of it will be posted on our event page, so please visit it afterwards. We will be doing some matchmaking as we link people with promising solutions and ideas with providers who need assistance. Please watch our event page for updated material. And the link is listed in the chat box. And this will remain live as we work through matching people and solutions over the coming weeks. Now, I do want to say a few thank yous. First, a big thank you to Mel for facilitating the pitches and solutions portion of this event. We truly benefited from the wealth of your experience and insight. I also want to thank all our keynote speakers and our pitch presenters for the insights they offered to help make these problems real. I also want to thank those who submitted pitches that we did not present orally on a video conference, but are still equally as important, and please take a look at them. And we look forward to following up with everyone who took part in the day over the coming weeks. I want to thank our partners at the University of Calgary, that's the O'Brien Institute for Public Health, W21C in Biomedical Engineering, and also the Brenda Stratford Foundation and the Glen Rose Rehabilitation Hospital for their hard work behind the scenes. This whole event was a bit like a duck swimming. It looked fairly calm, but I can reassure you that legs were paddling madly just below the surface. I want to specifically thank members of our steering committee and also the administrative staff who made this whole event possible. Brittany, Leora, Julia, Angela, Michael, Jeff, Jamie, Sophie, and Michelle. Thanks very much. I want to specifically thank two people who were critical. First, I want to thank Navjot Vert for kind of stirring the whole pot. Navjot was identifying with her colleagues at the Stratford Foundation and also colleagues throughout the continuing care sector, challenges and problems brought on by COVID-19. And I want to point out this all came together quite quickly. From start to finish to today was done in less than 6 weeks. And this would not have been possible without Anne Toohey, who really was the glue that held us all together. And they deserve our thanks. And thank you for attending, and we look forward to seeing some promising technologies put into place as quickly as possible. And please stay safe, everyone. Thank you.